Okay, hi everyone. Before I start, I got a confession to make. So my slide is going to be very short. I essentially read 5 to 7 slides as 5 to 7 minutes. So yeah, it'll be quick. Okay, so my
Okay,
topic.
one more thing to add. He took over another resident's topic. So this was rather last minute also. Yeah.
Yeah, so the specific topic given to me was biopsies during ureterorenoscopy, and specifically talking about these complications and how to prevent them. Generally, biopsies during URS or flexible URS is mainly done in the context of UTUC. So this a little bit of overlap with the Uro-Onco topic that we had earlier this morning. So this is where it lies when we look at the EAU guideline. Essentially, in a patient with a suspected UTUC, the initial diagnostic evaluations should include a CTU, urine cyto, as well as cystoscopy. And point to note is that flexible URS with biopsies is a plus minus on the EUA guidelines, of which I will explain further. Essentially, the main goal by performing this biopsy is to determine whether this UTUC is a low risk or a high risk UTUC. And defining this low risk or high risk UTUC according to the EAU guidelines are essentially these few. Sorry, just 1 second. I realized I need my notes. Huh? Oh no, can everyone see my notes? Sorry. Okay, great. Yeah. Okay, yeah, so essentially these are the criteria for between a low risk and a high risk UTUC. And if you look at the list, right, essentially a biopsy is only helpful in determining one of the many criteria over there. Most of them we can actually get from imaging as well as cytology, as well as other clinical factors prior to the biopsy itself. So I would like to split the complications with regards to flexible URS and biopsies into generic as well as specific complications with regards to this topic. So generic complications are essentially all the complications that are related to a flexible URS. This includes, first of all, high intrarenal pressures, which we all know that extremely, it can cause infection as well as bleeding. And extremely high intrarenal pressures can even lead to fornical ruptures, and in the context of malignancy can potentially cause perirenal tumoral spread. The other thing is that there is also possibility of physical damage to the ureter during this URS, which can cause mucosal injuries, subsequent strictures, and of course, every urologist's nightmare, the ureteric avulsion, career ending. 1 second. Okay, so really to minimize this risk, we just need to follow the specific principles when it comes to endourology, which is to minimize the irrigation pressure as much as possible, just to maintain clear vision. Being careful with the handheld pumps in order to minimize the intrarenal pressures. Do pre-op cultures, as well as give prophylactic peri-op antibiotics to minimize infections. The use of a ureteric access sheath seems like a double-edged sword from my readings, because on one hand, it sort of helped to reduce the intrarenal pressure, as well as to, which helps to prevent, decrease the potential septic complications. But on the other hand, this may increase the risk of strain-induced lesions to the ureter. Additionally, with the during the advancement of the UAS over a guide wire, it is most likely done blind. We are not able to visualize or be aware of the peristaltic movements of the ureter. So that in itself can cause some ureteric injury. But with the advancement of technology, we know that we are coming out with smaller scopes. So all these can help with irrigation, and in some selected cases, maybe pre-stenting can be a good idea to try and minimize all these generic complications with regards to URS biopsies. Now, moving on to the specific complications, there are actually 2 specific complications related to URS biopsies which I want to highlight. The first one is not specifically a complication, but it is one of the main problems encountered in these biopsies. And it is essentially the accuracy of these biopsies in relation to the actual specimen in RNU. So first off the get-go, around 20% of all biopsies in ureteric biopsy is actually non-diagnostic. Among those who are diagnostic, when compared to the final nephro-use specimen, around 5 to 16% upgrade from a low grade to a high grade disease. And around 45% of TA tumors are actually upstaged, while most T1 tumors, when the pathologists can confidently conclude that, are actually concordant. This most likely because most of the biopsies itself actually does not contain the lamina propria. It is also worthwhile to mention that the grade of the ureteric biopsy is actually a good predictor of the final stage of the nephro-U. So to prevent this issue, or rather to try and optimize the accuracy of the biopsy, first, we will need a good visualization of where the lesion is. It doesn't make sense if you go and biopsy the normal ureter and it comes out as non-diagnostic or like normal. So with good visualization, it can be done with the use of image enhancements, such as narrowband imaging, and the use of better high-definition ureteroscopes. This will make sure that we are truly taking a biopsy of the tumor and not any inflammatory tissue or any tissue that might look suspicious or cause, as a result of our procedure at the start. It is also shown that bigger specimens lead to better and more accurate diagnosis in URS biopsies. Hence, using a large biopsy forceps, such as a Biopsy backloading 10 French cup, can increase the size of biopsies. However, from my understanding, many people have said that there are other problems associated with this device, such as poor visualization and bleeding and so on. In the case of a polypoidal lesion, we can choose to use a basket instead of a cold cup biopsy. Additionally, we should always take selective upper tract cytology, as concordance with cytology increases the overall diagnostic accuracy of FURS of up to 90%. The second specific complication of URS biopsies, which I want to highlight, is the increased risk of intravesical recurrence of the tumor. So this is actually one of the main topics, which is why URS biopsies is so controversial, and which is why the EUA guidelines has a big plus minus over there. So there was a recent retrospective study published from Mayo Clinic back in 2021. They compared a series of 800 plus patients who have undergone RNU for UTUC, and they found that intravesical recurrence rate is around 15% for those who have not underwent any previous URS, around 18% for those who have underwent URS but had no biopsies, and around 22% for those who have underwent URS with biopsies. Statistically, there is no difference between those who have not received a URS and the group with URS but no biopsy. However, when compared with the group with biopsy, the group with biopsy has a higher recurrence rate, which is statistically significant. In that same study, they also did a meta-analysis including 11 other retrospective studies, which also show the same trend. However, when taken into context, it is important to note that although URS biopsies is associated with higher intravesical recurrence, it is actually not associated with overall cancer-specific or metastasis-free survival. So that's an important point to note. So to try and reduce this complication, the first thing we need to do is, of course, we need to reconsider who actually needs a URS or URS with biopsy. It should not be taken as a routine for all patients with suspected UTUC, and we should think about whether the biopsy really changes the subsequent management of this disease. There are also other non-biopsy related diagnostic tools that are up and coming that can help us with our management, such as imaging, urine cytology, and as well as urine biomarkers, which is something that is talked about but hasn't really been used. In cases whereby we deem that, okay, a URS is truly necessary, there are new technologies out there which may help us to essentially grade or even stage the tumor without a biopsy. And these are things such as optical coherence tomography, like the one ophthalmology used for their retina, confocal laser endomicroscopy, as well as endoluminal ultrasound. However, realistically speaking, even though we have all these big and wonderful fancy technologies out there, it is quite difficult for us to really trust our skill and as well as our interpretation when it comes to something so high stakes, such as subjecting a patient to a radical nephro-U. So there is this topic about chemical, or rather chemoprophylaxis after a URS biopsy. We know that there is level 1 evidence, meta-analysis of RCTs, that a single installation of intravesical chemo after TURBT decreases recurrence. And we also know from the ODMITC trial that there is a reduction in the risk of de novo bladder cancer following RNU when we give post-operative intravesical mitomycin. However, there has not been any good study looking into chemoprophylaxis in reducing intravesical recurrence after patients for patients who have undergone a URS biopsy. So, although this thing, this should instinctively work, that's what I think, but there isn't really good evidence out there yet. So this is something worth considering. Yeah, as I said, a 5 to 7 minute presentation. These are my references, and yeah, that's the end of my presentation. Thanks.